Hello, everyone, and welcome to this webinar in connection to Maurizio Nava's breast meeting. Ciao, Maurizio. Thanks for inviting me here, and I'm very happy to talk about why I do think that texture implants should still be indicated in breast surgery. So let's start by saying that the reason why we all gather in congresses and meetings, well, these are my disclosures. First of all, I am a speaker for Polytech. So the reason why we are gathering in meetings, hopefully soon again in person, but for the moment in webinars, is not because we're trying to tell people and surgeons that if they do the way we show in our presentations, that they're going to have zero complications. We all know, we all surgeons know that the only way we have to have zero complications and no unfavorable results is just to not operate, obviously. So we all know that when we do surgeries, we're going to have complications. The reason why we meet here is to try and say, okay, let's try and make sure that we can minimize the risk of the complication. If we try and follow some guidelines, then maybe we can have less problems. And actually, we do also know that the risk for complications in surgery actually starts before the surgery itself. And it starts at the moment we choose an implant, at the moment of the consultation, because it is absolutely true to say that we should use what we call the biodimensional approach to breast augmentation with focus on patient measurements and not only on volume like many surgeons still actually do. This will absolutely decrease the reoperations and improve patient outcomes. How's that? It is because implants that are too large, they're actually going to violate the natural borders of the breast footprint. And this will predispose basically to all kind of complications that we know in the catalog of breast augmentation, such as malposition, of course, soft tissue stretching, parenchymal atrophy, implant edge visibility, rippling, and anything else that we can count as a complication in breast surgery. And we also know that our first operation it's usually our best chance for a successful outcome, because normally secondary cases are much more demanding than primary cases. And for those of you who are interested, you can take a look at this article of mine, me and a few friends and colleagues of mine, that has been published on Aesthetic Plastic Surgery Journal just a couple of months ago, in which we have sort of tried to come up with a list of those that are controllable factors to reduce the rate of complications in primary breast augmentation. So if we go back to the title of my webinar, is why are texture implants still indicated? Actually, the answer to this question is very easy, and it can be just explaining one very simple slide. I actually think that texture implants should still be indicated because anatomical implants are textured, and I cannot run a practice of breast surgery without anatomical implants. I'm not saying that I only use anatomical implants, but I'm saying that I also use anatomical implants together with round implants. And if I were to use only round implants, if I was forced to discard anatomical implants, I would not be able to offer to my patients the set of options that I usually consider every time I do a consultation. So the reason why texture implants should still be indicated is because anatomical implants are textured. So if we look at this slide, we can take a look at the breakdown of the numbers, or the breakdown between the use of smooth versus anatomical implants in different areas. In the United States, there is a huge prevalence of usage of smooth implants, probably because also of the moratorium that the United States went through many years ago in regards to the use of silicone implants. While in countries as Europe and Australia, 90% of surgeons are actually using texture implants. But why are texture implants, attacked by some authors? What are the features of the texture implants? I try to summarize the features of texture implants in this slide. On one side, texture implants promote periprostatic capsular tissue ingrowth, which is the reason why they stay where they are. They shouldn't actually move. It's because of the prostatic capsular tissue ingrowth, and this increases the adherence to the capsule and limits the implant mobility. On the other hand, however, texture implants have irregular surface and an increased surface area, and this in turn provides a harbor for bacterial ingrowth and biofilm formation. We know that bacteria actually try and enter in the spaces made by the textures. So it is absolutely demonstrated how texture implants can provide a bigger harbor for bacterial ingrowth compared to smooth implants. So the biological advantages of texture implants, which is the fact that they have better tissue ingrowth as compared to smooth implant, the fact that anatomical implants are texture, so if we want to use anatomical implants, we need to use texture implant, and the potential reduction in the incidence of capsular contracture, at least in the submuscular space. So these biological advantages needs to be balanced by the increased risk for bacterial attachment, like I said before, with initial biofilm development. So all in all, why should we keep using texture and anatomical implants while there are a lot of authors, especially in the US, claiming that we shouldn't be using anatomical implants? They should just be banned or discarded. Well, I tried and summarized the points that usually these authors claim as to why we shouldn't be using anatomical implants. They claim that anatomical implants carry a higher complication rate, and in particular with the risk of rotation. They claim that there is actually no difference between anatomical implants and round implants, so why should we use anatomical if there is no difference? And also the risk for ALCL that has been demonstrated as way higher with the texture implant. So my question, the question that I am asking myself that I'm presenting you in this webinar is, are these 3 points that I have that I have summarized here, are these good reasons why, but most of all, are these true reasons why we should not use anatomical implants? Are these true reasons why we should discard anatomical implants? And what I'm going to try to do in this webinar, I'm going to try to go one by one these points to see whether or not there is any truth in these claims. For example, is it true that anatomical implants have a higher complication rate? What does literature say? Well, first of all, I want to show you a paper of mine together with a few friends and colleagues of mine that has been published on ASJ, Aesthetic Surgery Journal, a couple of years ago, that we called Do Not Fear an Implant Shape. And what we did there was basically analyze 648 patients operated all by myself over a period of time of 6 years, who had at least a follow-up of 6 years. Of these 648 patients, I had 9.4 patients with complications, which is completely in line with what literature says. But the interesting finding of this paper of mine was that of these complications that I had, almost 12% of the complication occurred with round implants, while only 9% of the complications occurred with anatomical implants. So I had more complications with round implants compared to the complications that I had with anatomical implants. But yes, this is only my finding, only one surgeon's finding. So we went back to the literature and see what literature had to say about this. And we found that core studies from Allergan and Mentor, which is the biggest core studies out there, with follow-up up to 10 years, the overall risk for complications, so any complication, capsular contracture, malposition, seroma, rippling, any complication, was actually higher, even in the core studies with round implants when compared to anatomical implants. It is true that the follow-up of my paper is shorter because it's not 10 years, obviously, but still, there is the same trend. In my studies, I have a higher risk for complication, a higher incidence of complication with round implants. In the core studies, there is a higher risk, a higher incidence for complications with the round implants. Moreover, I was able, together with some other friends and colleagues, to publish this other paper on PRS last year, where I was actually trying to do something else. I was trying to benchmark the outcome of single-stage mastopexy augmentation against primary breast augmentation to see if there was a difference in terms of complication rate. So analyzed the 905 patients over a period of time of 8 years with the follow-up more than 6 months, all of them operated by myself. And for those of you who are interested, the number of complications were similar, both in the group of primary breast augmentation and in the group of mastopexy augmentation in one stage. But what's interesting in regards to this matter that we're treating today is that even in the case of primary breast augmentation versus mastopexy augmentation, even when considering mastopexy augmentation and not only primary breast augmentation, I still had more complication using round implants. So not only did I have more complication in all my primary breast augmentations when using round implant compared to anatomical implants, but I also had more complications with round implants when performing one-stage mastopexy augmentation. It's quite an interesting finding. I mean, the same trend in different operations. Also, if we go and check the core studies from Allegan, and we consider the risk of malposition only, because many authors, they claim, okay, yes, sure, but anatomical implants, they can rotate. Okay, sure, anatomical implants is true, can rotate, while a round implant cannot rotate, but rotation is just one of the possibilities of malposition. And malposition does not only include rotation. Malposition includes all other situations in which the implant is not sitting where it should sit, for example, bottoming out. So if we go and see not only general complication, but specifically the malposition risk with round compared to anatomical implants, in the core studies, we have that round implants have a higher rate of complications where compared to anatomical implants. What can be the reason for that? Well, it could be that there is an increased adherence of the texture surface implants that makes them stick together with the tissues, and so the malposition could be less likely with a texture implant as compared to smooth implants. But with this other publication of mine that you see here, published on ASJ 2017, I came up with the hypothesis that the reason why there could be more malposition with round implants when compared to anatomical implants is because a round implant with a given width, with a given width, same width as an anatomical implant, a round implant is always bigger, and for this reason heavier. You can see it here in this graph. The blue line is round implants of a given projection and of a given width. So here we have a low projection, moderate projection, full projection, extra full projection. In each case, with a given width, the round implants have a higher weight. So that's a possibility. That could be an hypothesis as to why round implant could malposition more frequently as compared to anatomical implant. They are heavier, in other words. So back to my list here, one of the 3 claims according to which we shouldn't be using anatomical implants, higher complication rate of anatomical implants, is completely proved wrong, both by my studies, but especially by literature. It is not true that anatomical implant come with a higher complication rate compared to round implant. It is actually true the opposite. Round implant have a higher complication rate. Round implant have a higher rate of malposition even. Let's go now and see what about the fact that some authors claim that there is no difference between anatomical and round implant. And this is actually also an interesting thing, because oh yeah, no, sorry, I forgot one thing that was very interesting when it comes to the fact that still back to the claim that there is higher complication rate between anatomical and round implant. I have now presented the numbers and studies comparing round smooth implants to anatomical texture implant. So one might argue, okay, you compare these categories of implants. How about nanotexture? We know that nanotexture, they are considered as smooth implant, but it's still a new surface. So is there any comparison at all in literature between texture implant and nanotexture implant? Well, there wasn't up to 1 month ago when, together with my friend Vincent Tay from Singapore, we have actually managed to complete this study that has been published on Aesthetic Surgery Journal just a couple of weeks ago. So it's very interesting for you guys to go and have a look at it, because it's a brand new article that we're very proud of. And in this article, what we did was we studied 415 consecutive patients of breast augmentation, all operated by myself over the time 2016-2019, and of which around 61% were conventional texture implant, and the rest were nanotexture implant, with a mean follow-up of slightly more than 2 years. So what were the findings in this article? Well, we divided, for the purpose of studying, these 415 patients in 3 chronological groups, so like 130 something patients in each group. And you can see here that at 1 year follow-up, the total overall complication was 0.8% with texture implant, and it was 6.8%, so 7 times as much with the nanotexture implants. When it comes to the overall complication, so after 2 years and something of follow-up, this gap is less wide, but still the overall complication rate of nanotexture implant was more than twice the complication rate that I had with texture implant. So again, texture implant, at least in my study, have less complication rate than smooth implant, less complication rate than nanotexture implant. How about the effect of implant surface on secondary cases, on when it comes to the recurrence rate of capsular contracture? There are no studies whatsoever in literature, and I have a paper under peer review right now, which I hope is going to be published soon. We are actually undergoing revision, so hopefully it's going to be published soon. So what we did here, we analyzed 80 patients, 80 consecutive patients who underwent revision for capsular contracture, all of them operated by myself. And what I did for these 80 patients was exactly the same thing. I did capsulectomy. I changed the site of the implant, the pocket site of the implant, and I changed the implant, so new implant in. I had 2 groups. One group of patients with time between primary and secondary surgery of around 59 months, and the second group with time between primary and secondary surgery of 65 months. So basically very close to each other, with a mean follow-up also very close to each other, around 2 years. The interesting finding was that in the group A, I changed the implants from texture to a new texture. In group B, I changed the implant from texture to a nanotexture implant. All the rest of the operation was the same. And what I could see after 2 years follow-up was that I had exactly the very same complication rate of capsular contracture. So I had 3 cases of recurrence of capsular contracture in both groups. So also in this case, well, this paper is not yet been published, but anyway, this is my data that I'm presenting. It is also not true, not even in secondary surgeries, that round smooth implants, or in this case nanotexture implant, can have less complications or less risk for complication. In this specific case, capsular contracture compared to texture implant. In this case, the complication rate was just exactly the same. However, it is extremely important to point out how anatomical implants do have a learning curve, which is actually one of the reasons why many people don't like them, because it is more difficult to use them. It is way easier to use round implants as compared to anatomical implants. For this reason, many surgeons, they just claim, well, whatever, why should I use anatomical implants when I can have round implants? And people say that there is no difference with anatomical implant, less complications, so forth. learning curve, like I was saying, and this has been proved by a paper of mine that has been published a couple of years ago on Aesthetic Surgery Journal, when I did a very interesting study. I analyzed my very first 620 operations with at least 6 months of follow-up over a period of time of 7 years. So from my very first breast augmentation to my breast augmentation number 620, all of them with anatomical implants to see if there was a learning curve. I had a percentage of rotation of 3%, which is completely in line with literature. And for the purpose of study, I divided these, what was it now, 620 patients in 5 chronological groups, each containing 124 patients. So the first group was from first breast augmentation to breast augmentation number 124. Then the second group from breast augmentation number 125 to breast augmentation number 248, and so forth. And you can see here the graph is very clear. In the first 2 groups, I had 8 rotations, and I wasn't getting any better. But look what happens. The more breast augmentations I do, the better I become. Only 1 rotation in the further groups, showing very clearly that there is a learning curve. When you start, you will have more complication, but later on, these number of complications are gonna go down, which is pretty much obvious to understand, because each new technique needs to have a phase of adjustment. And for those of you who are interested, since this is a very interesting matter of discussion, topic of discussion in many cases, I had this paper of mine published with a couple of friends and colleagues of mine on PRS a couple of years ago, in which I tried to analyze if there were any particular factors that could be linked to a higher risk of rotation. What I did, I analyzed 531 breast augmentation with anatomical implants operated by myself over a period of time of 6.5 years, with basically the same percentage rate of slightly more than 3%, 3.5%. And I tried to examine if there was any correlation between rotation and predisposing factors. What I found was that there was actually a statistically significant correlation between rotation and preoperative breast cup size, meaning the bigger the breast was before surgery, the higher the risk for rotation I could have after surgery. Why that? Probably because a bigger breast calls for a bigger dissection, obviously. Bigger dissection means probably more fluid inside the pocket at the end of the operation. And we know that the fluids are the prerequisite for non-adhesion, which is very important for anatomical implant. They should stick to the tissues. And if we have fluid inside the pocket, this mechanism, this sticking of the implant can be actually compromised. And there was a trend, even if that didn't really reach the level of statistically significance, between rotation and BMI. So again, the bigger the patient was, the higher the risk for rotation. So very, very interesting. In this case, if I have a patient that is very big, maybe I can actually consider to choose a round implant, because I know that the risk for rotation with an anatomical implant could be higher. So let's go back to the list here. We have already proved wrong the fact that there is a higher complication rate with anatomical implant. That is not true. It's actually true the opposite. How about the claim that there is no difference between anatomical and round implant? Is that true? Well, first of all, when I hear people say there is no difference between round and anatomical implants, okay, but wait a second. What are we talking about? Are we talking about that there is no difference in terms of a final outcome in the appearance, meaning that if you do a breast augmentation with a round or with an anatomical implant, then there is no difference? Or are we speaking about that there is no difference in indication for use, which means that in any given patient, it doesn't matter if you choose a round or an anatomical implant, you will still have the same result, because these are very different things to analyze. So let's have a look at both of them. So is that true that there is no difference in appearance? This is actually being brought up by a couple of articles written a few years back by Hidalgo and Ruby. The problem is that during their articles, they excluded in their studies those patients who actually specifically need an anatomical implant. So breast with asymmetries or chest wall deformities, short lower pole. When the lower pole is contracted, there is a strong indication. This is basically accepted by all authors. And in these papers that have been presented by these two authors, they only basically operated, so to say, easy breasts. Those patients that, when we see them in our consultation, we feel home already, because that they are easy. But in the more difficult cases, those were actually not considered by these authors when they did these two publications, because these are precisely the individuals in whom the largest differences in indications for use and aesthetic outcomes might have been evident. And we actually know that there is a difference in the appearance of breast augmentation, and the difference is much higher if the soft tissue envelope is poor. Think of a girl who is skinny, like super skinny, and if you put an implant that is round, it will obviously have a complete other appearance compared to a patient that gets an anatomical implant. Same, if we place the implant subglandulary or under the muscle, we will have a difference in terms of the final outcome. Also important to consider the filling material. If it is highly cohesive, we can have a much more evident difference. If the projection of the implant is full or extra full, the difference between round and anatomical implant is going to be more obvious. And of course, the larger the implant is, the more the difference will be between a round and anatomical implant. But also, one thing that I think it's so obvious that has not really been considered by these authors, Hidalgo and Ruby, when they published their papers, is that if we really want to make a comparison, we need to compare an apple with an apple. We can't compare an apple with a pear or with a banana. So here, look at this picture. This is the same patient with a round implant or with an anatomical implant. And I think every single person, plastic surgeon or not plastic surgeon, could point out which one is round and which one is anatomical. So if a comparison is attempted, it should be made between either the same patient or two patients that look exactly the same. You can't compare the result of an operation with two patients whose body features are completely different with each other. That doesn't make any sense to me. So again, there is a big difference in terms of final outcome when it comes to round and anatomical implants. But how about the indications for use? Is it really the same? Can I use either anatomical or round implant in each and every patient? Is that really so? Well, obviously that is not the case. As pointed out by this paper of mine, 2017, again on Aesthetic Surgery Journal, in which I pointed out how there is a considerable variation in patients' body shape, as well as soft tissue cover and distribution. So any one shape of implant, round or anatomical, can never provide consistent result, meaning the same result in every patient. Or in other words, one shape is never a priori better than the other shape. It is, however, true, which is what Hidalgo and Ruby wrote in their paper, that in a subgroup of patients, those who are easy, look at this, those with good basic breast and chest characteristic, either shape can give a good result. Look at this. This is a patient operated with an anatomical implant. This is a patient that looks very similar, operated with a round implant. If we compare, we have a fantastic result with either implants. Anatomical implant on the left, anatomical round implant on the right. And again, I'm comparing an apple with an apple. I'm comparing two patients that looked basically the same before surgery. However, this does not hold true for every patient, meaning that in other subgroup of patients, say for example, those who have constricted lower pole, a tuberous breast, only if an implant is used with the appropriate indication, the patient will have a good outcome. And this is the diagram that I put up to explain what I'm trying to say. Any patient cannot just have any implant. If, like I said, I have a patient with a constricted lower pole, very tuberous breast, I cannot use a round implant. I will have a bad result, I promise you. A lot of patients, those who are easy patients, can have both, but the indications for use are actually very strong in some instances. So it's very important to understand that it is not true that there is no difference between round and anatomical implants when it comes to indications for use, and for sure it's not true that there is no difference in terms of final outcome between round anatomical implants if the patient compared are comparable, just like as simple as that. How about, and for those of you who are interested, this other publication of mine written with a fantastic list of authors a few years back on PRS, explaining the indications for use and to choose in the best way between anatomical and round implants. How about ALCL? Well, obviously, I cannot sit here and say ALCL doesn't exist. ALCL does exist, and absolutely, ALCL is very serious. However, it remains a rare complication, and we know that when ALCL started to come around a few years back, FDA came up with a statement, no change in clinical practice. But besides all this, what we know is that things have changed compared to a few years back, because now we know basically everything about how ALCL presents itself. So it is way more difficult nowadays to miss a diagnosis of ALCL. So it's probably also in this sense, it is still a serious disease, but probably less complicated to diagnose and cure. Moreover, we know that 84%, so almost all of them, of the cases of ALCL were linked to the biocell surface. But now biocell surface is gone from the market for good, which means that we have eliminated the cause of ALCL, or at least the cause of 84% of the cases of ALCL. So it's like a tiny number of implants that are still there that could cause ALCL, microtexture implant, but we know that the risk of ALCL with microtexture implants is way lower than the risk carried out by microtexture implants that are not currently available on the market. So of course, removing all anatomical texture implants from the market, just like some authors suggest, could eliminate the risk completely. We would have zero risk of ALCL, but this would also eliminate their benefits, leaving limited options for the surgeon and the patient. So my suggestion is talk to the patient, inform the patient. If a patient comes to me and she has a very constricted lower pole, and I know that I will have a terrible result with a round implant, I tell the patient, look, I need to use an anatomical implant, microtexture anatomical implant. You have a risk for ALCL, which could be, I don't know, 1 out of 300,000 or something. So if you get ALCL, we know now how, we can diagnose it and how to cure it, but still you have this risk. What do you want to do? Do you want to have a bad result right away from day one, or are you accepting the risk of having this tiny risk of having ALCL? I tell you that 99.9 of my patients, at least, are going to go for the anatomical implants. And also, I haven't put it here in my presentation, but there is this article published a few years back about micromorphs showing, that the risk, for example, of dying during a weekend in New York is much higher than having an anatomical implant in the body. So, I mean, it's all about informing the patient properly. And also, even in the worst case, that with the biocell implants, the risk is estimated as 1 every 30,000. So this means that each plastic surgeon won't even face a breast BILCL in his career. I think so far I am up to 1,000 and probably 700 breast augmentations. I will never reach 30,000. So maybe, hopefully, I'll never see one single case of ALCL in my series. I haven't so far. This is exactly what I said. If a patient comes with a constricted lower pole, I have to tell the patient exactly what it's about and make her make an informed choice of which implant is better for her. And actually, I found this quote from this Nobel laureate psychologist, Daniel Kahneman. I have no idea who he is, to be honest, but I really like the statement that he came up with, which is there is a basic limitation in the ability of our mind to deal with small risks like ALCL. We either ignore them altogether or give them way too much weight. We cannot find anything in between. And that's actually what happened with ALCL. As soon as it came around, there was like an explosion of authors suggesting that anatomical texture implant should be, instantaneously removed by the market. So, in conclusion, why do we still need anatomical implants? Everything you heard in this webinar of mine can be found on this fantastic paper that I published. Just look at the list of authors that are with me in this paper. It's outstanding. And so we actually put out a list of reasons as to why anatomical implants should still be considered as a valid alternative in primary breast augmentation. A single ideal implant that is suitable for each and every primary breast augmentation does not absolutely exist. And together with smooth implants, I never said, not once in my webinar, that I'm not using round implants, that I think anatomical implants are better than round implants. I never said that. I just said that texture anatomical implants together with round implants should be considered as one of the tools in the surgeon toolbox. By choosing to ignore them, by choosing to ignore anatomical implants a priori, the surgeon will only have access to half of this armamentarium. I usually pull a joke here and say it's just like a lawyer. If you run into trouble and you turn to a lawyer who will help you and he only knows half the law book. What if your case falls in the half of the law book that the lawyer doesn't know? It's the same here. If you only use round implant because you have decided to ignore anatomical implant, and you have a patient that comes to your consultation and she has a very constricted lower port, for example, and you ignore anatomical implant, you will not get a good result. I am very positive about this. So those who actually remove part of the armamentarium, removing the anatomical implants, they will be able to offer a limited set of options to his patients. So the optimum choice of the implant to provide the best individualized outcome in any given situation is determined by the list of these parameters that I put here. So patient's physical characteristics, available implants type, the surgeon experience, why not? Absolutely. Evaluation of patient's risks and benefits together with patient's wishes and expectations. Thank you very much for listening to this webinar of mine. So in case there are any questions, I will be able and very happy to answer them via chat. Let's see if I can take them up. So there is Anna who is asking me if the indications that I have explained are actually applicable to breast reconstruction. And I would absolutely say yes. Absolutely yes. There is no reason why the same indication shouldn't be applied with breast reconstruction. I mean, all in all, breast reconstruction is an aesthetic procedure. We are trying and make the breast look again the way it was before the unfortunate cancer event. So absolutely, my answer is yes. So I can't really see here in the chat more questions. So I will be able to answer, this webinar is obviously recorded. And so for those of you who are not seeing the live thing, it's totally okay to send questions, and maybe we can also go through this more discussion during the Maurizio Nava breast Congress live event on internet, again, live streaming, that's going to be held between the end of November and mid-December. So from my side, this is all. Thank you so much for following. Have a great day. Greetings from Stockholm. Beautiful Stockholm today, actually. We have 18 degrees here, a beautiful sunny day. Hope it's the same for you. Take care. Thanks for following. Bye-bye.